Hello everyone and welcome to our module on osteoporosis. Osteoporosis literally means porous bone. If you look at this picture on the slide, this is what normal bone architecture looks like, and you can see that there are some pores found in bone, but in osteoporosis the porousness of the bone is greatly increased. And when this happens, there will be a low bone mass in the body and also bone density, and we'll talk more about how these things are measured in just a minute. But clinically, what happens in osteoporosis is the bones become weak and prone to fracture, and usually osteoporosis is asymptomatic until fractures occur. There usually aren't any symptoms like bone pain or tenderness that suggest a diagnosis until a fracture develops. There are two ways to make the diagnosis of osteoporosis. The first is if the patient suffers a fragility fracture. A fragility fracture is a minor fall from a standing height or less, and it's not related to a major trauma like a motor vehicle accident. These are minor falls that should not cause bone fractures, but when they do, we call that a fragility fracture. Fragility fractures commonly involve the spine or the hip. Many patients in the hospital with hip fractures, when you take their history, the hip fracture occurred due to a relatively minor fall. That's a fragility fracture. Other places where these fractures occur include the wrist and humerus, the ribs, and the pelvis. And then besides a fall from a standing height or less, another example of a fragility fracture is a spontaneous vertebral compression fracture. These are fractures involving the vertebra of the spine, and they occur spontaneously caused by the patient's weight on the vertebra. And then the second way that you can make the diagnosis of osteoporosis is by doing something called a DEXA scan and identifying a T-score of -2.5 or lower. DEXA stands for dual energy X-ray absorptiometry. And this is a test that involves two X-rays of different energy levels that are aimed at bones. That's why it's called dual energy. This is a picture of a man having a DEXA scan on the screen here. This test will generate a T-score, which is a comparison of the patient's bone mineral density versus the bone mineral density in a healthy 30-year-old. A normal T-score is -1.0 or higher. These patients have the lowest risk of fractures. Osteopenia is defined as a T-score from -1 to -2.5. And osteoporosis by definition is -2.5 or lower. Patients with these T-scores have the highest rate of developing fractures. Current guidelines in the United States recommend screening women for osteoporosis with a DEXA scan every 3 to 5 years for all women who are 65 years of age or older and women under 65 who have risk factors for osteoporosis. And we'll talk about what some of these are in just a minute. Screening is not currently recommended for men. The rate of developing osteoporosis in men is much lower than in women. To understand why osteoporosis occurs more commonly in women compared to men, let's talk about how bone mass changes over the course of our lifetime. If you look at this graph on the screen of age in years along the x-axis and bone mass on the y-axis, you can see that in both males and females, bone mass peaks in young adulthood. And the height of the peak bone mass has many influences, not just the patient's sex, whether they are male or female, but also genetics, diet, and other things. After peak bone mass is achieved, it declines slowly thereafter over the course of our lifetime. And that's because our bones are constantly being resorbed and formed over our lifetime, and with each resorption and formation cycle, there's a small degree of bone loss. As you can see in the graph, males achieve a higher peak bone mass compared to females. And also shown in the graph is that bone loss accelerates due to menopause in women. That's because when estrogen levels fall during menopause, this leads to accelerated bone loss. And so for both of these reasons, female osteoporosis is much more common than male osteoporosis, although osteoporosis in men does occur in a minority of cases. And then another thing to be aware of regarding bone mass is that weight-bearing activity and exercise increase the bone mass and decrease the risk of osteoporosis. And we'll come back to this later in this video when we talk about how to prevent osteoporosis. Some of the important risk factors for osteoporosis are shown on this slide. The first is alcohol. So heavy use of alcohol has been associated with a higher risk of osteoporosis. More moderate use has effects on bones that are not clear, and moderate use has not been tied to an increased risk of osteoporosis. Smoking can lead to osteoporosis because it accelerates bone loss. And then low body weight, usually defined as less than 127 pounds, increases the risk of osteoporosis. And that's because patients with higher body weights bear more weight on their bones, and this leads to a higher bone mass. And then finally, as we saw in the last slide, bone mass declines with age, so advanced age is also a risk factor for osteoporosis. You can break down osteoporosis into two subtypes. The first is primary osteoporosis, which is the most common form. Sometimes this is even subdivided further into two types. There's postmenopausal osteoporosis, or type 1, which is caused by deficiency of estrogen. This is what occurs in women after menopause. Senile primary osteoporosis, or type 2, is age-related bone loss, and this occurs in both men and women, as we saw on that graph a few slides ago. Distinct from primary osteoporosis, however, is secondary osteoporosis. This is not related to menopause or aging. This form of osteoporosis should be suspected in premenopausal women because usually before menopause women do not develop osteoporosis. And secondary osteoporosis is caused by either drugs or another medical disorder that leads to accelerated bone loss, unrelated to menopausal estrogen deficiency or aging. One of the very common causes of secondary osteoporosis is chronic use of glucocorticoids. So many patients take glucocorticoids like prednisone daily for suppression of autoimmune disease, and over time this leads to secondary osteoporosis. Glucocorticoids affect osteoblasts and osteoclasts, the two cell types that are responsible for formation and resorption of bone. They lead to increased bone resorption and reduced bone formation, and therefore osteoporosis can develop over time. Use of certain anti-epileptic drugs is also associated with secondary osteoporosis. The major culprits are phenobarbital, phenytoin, and carbamazepine. These drugs are used to treat seizures and epilepsy disorders, and there's a risk of osteoporosis when they're used for long-term therapy. The mechanism is that these drugs increase the activity of P450 enzymes in the liver, and this increases the breakdown of vitamin D. And when there's less vitamin D, there's less calcium in the body, and this leads to a rise in the parathyroid hormone level, and parathyroid hormone level causes bone loss, and that's how these drugs can lead to secondary osteoporosis. The anticoagulant unfractionated heparin is associated with secondary osteoporosis. This only occurs with long-term use, which isn't done much in the modern era, but if you administer unfractionated heparin for a long period of time, it will decrease bone formation and increase bone resorption. This is only described with unfractionated heparin. Low molecular weight heparin has unclear bone effects and may not lead to secondary osteoporosis with long-term use. And then finally, secondary osteoporosis has also been associated with several nutritional deficiencies. So vitamin D deficiency technically leads to osteomalacia, which is decreased calcium in bones. It's slightly different from osteoporosis, but nevertheless, deficiency of vitamin D has been associated in some studies with secondary osteoporosis. The same is true of calcium deficiency, and when patients have malabsorption, for example from celiac disease, they can underabsorb calcium and vitamin D, and this can lead to secondary osteoporosis. Secondary osteoporosis is usually suspected when osteoporosis develops in premenopausal women, because usually women do not develop osteoporosis until after menopause. When this happens, the first thing that should be done is a history and physical exam, because often the cause of secondary osteoporosis is obvious from the history and physical, for example, if the patient is taking chronic glucocorticoids. When the cause is not obvious from history and physical exam, some of the testing that can be done is shown in this table on the screen here. So a CBC is often done to screen for anemia, and that's because anemia is common in patients who have celiac disease. They can have malabsorption of iron and also sometimes B12 and folate, and this can lead to anemia. A calcium and vitamin D level are usually measured. A TSH can be done to screen for hyperthyroidism. Calcium and phosphate measurements are used to screen for hyperparathyroidism, and then if there's a strong suspicion of hyperparathyroidism, a PTH can also be measured. And then lastly, patients with chronic renal or liver disease can develop early osteoporosis through a number of mechanisms, so a creatinine and liver function test can also be checked to screen for liver and kidney problems. Once you make the diagnosis of osteoporosis, either through a fragility fracture or a DEXA scan, let's talk about the treatment of the condition. So treating osteoporosis begins with lifestyle modification, which usually involves three things: weight-bearing exercise, avoiding heavy alcohol use, and smoking cessation. Weight-bearing exercise is exercise while standing and bearing your body weight. This can increase bone mass and slow the rate of bone loss over time. So examples of weight-bearing exercise are walking and hiking, jogging, or playing tennis, things like this where the patient is standing and bearing their body weight. Weight-bearing exercise is not swimming, cycling, or rowing because in these activities the patient is sitting or otherwise not bearing their body weight. And make sure you know how to identify specific examples of weight-bearing exercise. They're going to want you to know these things on your exams. And then besides lifestyle modification, patients diagnosed with osteoporosis should take calcium and vitamin D supplements. The usual recommendation is 1,200 milligrams a day of calcium and 800 international units every day of vitamin D. Besides those things on the last slide, the mainstay of medical therapy for osteoporosis is treatment with bisphosphonate drugs. This includes drugs like alendronate, risendronate, and similar sounding medications, and these are all first-line medical therapies for osteoporosis. All of the bisphosphonates are analogs of a naturally occurring substance called pyrophosphate, which binds to bone and inhibits osteoclasts so that they can't break down bone. They're called bisphosphonates because their molecular structure contains two phosphonate groups. Those are these phosphorus-containing groups here. And then all the bisphosphonates have two attached groups called R1 and R2, and they vary by their R1 and R2 group, and that's what distinguishes one bisphosphonate from another. But all the drugs function similarly by inhibiting osteoclasts, and some of the drugs are oral and others are administered through an intravenous infusion. The oral bisphosphonate drugs include alendronate and risendronate, and the thing to know about these drugs for your board exams is that they commonly cause GI upset, especially problems in the esophagus like reflux symptoms and heartburn, esophagitis, and potentially esophageal ulcers. And these are all caused by local effects of the bisphosphonates on the esophageal mucosa. So because of these adverse effects, these drugs are usually not used in patients who have esophageal disease. When they are used, they're taken weekly, and patients are instructed to take them with a glass of water on an empty stomach and then remain upright for 30 minutes after taking the medication. And all of these things are done to prevent the development of esophageal symptoms. The intravenous bisphosphonates include alendronate and ibandronate, and these drugs are given as an intravenous infusion over about 30 minutes or so. They're often administered in an infusion clinic. And these drugs are nice options for patients who can't tolerate the oral medications because of esophagitis and other problems. The adverse effects of the IV bisphosphonates include flu-like symptoms, which can develop 24 to 72 hours after the infusion. This includes things like a low-grade fever and myalgias. It usually responds to treatment with ibuprofen and acetaminophen. And good things about the intravenous bisphosphonates is that they have long dosing intervals. They can be given every 3 months, or in some cases they can be infused once per year. And then there are some rare but serious adverse events that have been associated with many of the bisphosphonate drugs, so let's talk about those now. The first is atypical femur fractures, which refers to fractures of the femur in unusual locations, usually below the lesser trochanter. If you look at this drawing on the slide here, this is the lesser trochanter, and most femur fractures involve the neck or the head. They're in this region up here. Rarely in patients taking bisphosphonates, they can develop fractures below the lesser trochanter or in other unusual locations, sometimes after no or minimal trauma. And most of the reports of atypical femur fractures have been in patients who have been taking bisphosphonates for at least 5 years or longer. And then osteonecrosis of the jaw refers to pain and swelling of the mandible. It can lead to exposed bone and local infection, and there can be pathologic fractures of the jaw as well. Most of the reports of osteonecrosis of the jaw in patients on bisphosphonates involve patients who had cancer. We'll talk about this in a minute, but bisphosphonates can be used to treat patients with metastatic cancer to the bones, and those were many of the cases in which osteonecrosis of the jaw occurred. Probably immunosuppression from cancer played a role. So there are some other indications for bisphosphonate drugs besides osteoporosis. One of these is hypercalcemia. Because bisphosphonates decrease bone resorption, they lower the serum calcium, and in fact they can in some cases cause mild forms of hypocalcemia, and so for this reason they can be used to treat patients who have hypercalcemia. Paget's disease of the bone is a disorder of focal abnormal bone growth, and it can be treated with bisphosphonates. And then, as I just mentioned, in patients who have cancer who have metastatic bone disease, bisphosphonates have been shown to improve a number of outcomes. They decrease the rate of pathologic fractures and spinal cord compression. They also improve hypercalcemia of malignancy. They also decrease the need for radiation or bone surgery to treat bone metastases. So the mainstay of treating osteoporosis is with bisphosphonates, but there are some other treatments which can be used in patients who are unable to take bisphosphonates for any reason, or sometimes in patients who don't respond to bisphosphonates. And so all of these drugs listed here can be used for this purpose, and we'll go through each of them in the last few slides in this video. Teriparatide is recombinant human parathyroid hormone, or PTH, and you may know that the way PTH works is it causes bone resorption to raise the serum calcium. So you may be wondering why we would give a drug that works like PTH to patients who have osteoporosis. Well, it turns out that the continuous administration of parathyroid hormone causes bone resorption and raises serum calcium. And this is important physiologically. This is how the naturally occurring PTH in our body works. If, however, you give parathyroid hormone as a low-dose, once-daily bolus administration, it has a different effect. When given this way, parathyroid hormone increases bone mass. It actually causes osteoblasts to lay down and form more bone, and that's why a once-daily dose of parathyroid hormone in the form of teriparatide is beneficial in patients who have osteoporosis. It can be administered as a subcutaneous daily injection. Teriparatide is generally well tolerated. In a minority of patients, it may cause nausea or dizziness. And then one special side effect you should be aware of is transient hypercalcemia. Remember that teriparatide is recombinant PTH, so it can have some PTH-like effects, which include raising the serum calcium. So after patients take this drug, there's a brief rise in serum calcium, but the drug has a quick on and off effect over hours, and rarely does teriparatide lead to very high levels of calcium or symptoms of hypercalcemia. Usually within a few hours, the levels return back to baseline. Raloxifene is a SERM, which is a selective estrogen receptor modulator, and it's called a SERM because it has pro-estrogen or anti-estrogen effects depending on the specific tissue you're talking about. So in bones, it has estrogen actions, and this is a good thing. It promotes bone formation, and that's why raloxifene can be used in osteoporosis. It has anti-estrogen effects, however, in breast tissue, and this is actually a good thing because drugs that have estrogen effects in breast tissue can raise the risk of breast cancer, but raloxifene reduces the risk of breast cancer. Raloxifene can cause hot flashes. This is due to anti-estrogen effects, and then it's associated with an increased risk of deep vein thrombosis and pulmonary embolism, and many drugs with some estrogen properties can lead to a higher rate of DVT or PE. In the uterus, raloxifene has minimal effects on estrogen receptors, so it's not associated with bleeding, uterine hyperplasia, or uterine cancer like other pro-estrogen drugs are. Calcitonin is a hormone normally produced by the thyroid gland. It binds to osteoclasts and inhibits bone resorption, and that's why it's beneficial in patients with osteoporosis. Calcitonin that comes from salmon, from fish, is what's used to treat osteoporosis as a second-line therapy. It's administered as an intranasal spray, and in terms of side effects, it may cause hypocalcemia. This is the same effect that naturally occurring calcitonin has, and because it's a nasal spray, it may cause rhinitis. And then our last drug for this video is denosumab, which is a monoclonal antibody to RANKL. RANKL is a protein that's expressed on osteoblasts, and it binds to the RANK receptor found on osteoclasts. And when this happens, the activity of osteoclasts goes up so that more bone is resorbed. So by using an antibody in denosumab that blocks the RANKL receptor, there's less binding to RANK and less osteoclast activation. Denosumab is given as a subcutaneous injection every 6 months, and it's generally well tolerated with few adverse effects. And that concludes our module on osteoporosis.